topics that are super, super high yield yesterday on our live classes. As you know, now we provide live and unlimited on-demand classes. In fact, you can attend as many live classes as you need in order to support you and make sure that you pass the board with easy as possible. So, as we discussed, even today, when you are dealing with easy topic, I can almost guarantee you that you will get a hard question. Topics like what's tolerance, right? It's something that we know since nursing school. We need now more drugs to achieve the same results. But make sure that you understand it, tolerance in its uh full understanding of what it is and what it's not. What is kindling? Kindling is nothing but a decrease the seizure threshold. Okay. When we decrease the seizure threshold, for instance, when someone is drinking heavy alcohol and they stop cold turkey, then their threshold for seizure decreases. And every time they do that, it decreases lower and lower and lower until they have a seizure. The subject of addiction, right, is defined as a chronic relapsing disorder characterized by compulsive drug seeking. Now, it's despite adverse consequence, knowing what's dependency, tolerance, and addiction is high yield. So, addiction, you are doing the drug despite of losing your job, breaking your marriage, financial troubles, being late at work, going to jail, right? So relapsing disorder characterized by compulsive drug seeking despite adverse consequence. So no tolerance, addiction, and the minimum what else? So tolerance, addiction, dependency is important as well. Potency, we are talking about what 1 milligrams from, for example, Haldol versus 5 milligrams from chlorpromazine. If they were both the same if they are both the same category, how much of one drug takes the other drugs of a higher milligram? So the one that has lower milligram has a high potency, and the other that has a larger, bigger milligrams would be low potency, given that both drugs are in the same class and do the same thing. We talked about ADHD, three types of ADHD. We have the inattention type, or inattention. The second would be hyperactive and impulsivity. And the third would be both. We discussed what the inattention symptoms entail. Questions likely give you the symptoms and tell you which type of ADHD it belongs to. We talked about the types of symptoms of hyperactive, impulsive, and we talked about when they are both mixed. You really need to know where the etiology or where ADHD comes from. From now on, every time you hear ADHD, you should know it comes from the prefrontal cortex, basal ganglia, and reticular activating system. When we talked about ADHD, from the prefrontal cortex and basal ganglion, we are concerned about motor learning function, emotions, and executive functions. When it comes from the reticular activating system, we are talking about ability to focus, the of flight or fight response, and sleep awake transitions. We also talked about a lot of neurotransmitters and their corresponding disorders, one of them being ADHD. You should have a white piece of paper that you write down all your neurotransmitters in it. And for the bucket of DNS, dopamine, norepinephrine, serotonin, under that you should put ADHD, major depressive disorder, and Tourette's. How to manage ADHD. We talked about the two types of stimulants mainly, amphetamine and methylphenidate. You should know that amphetamine 3 years older and older, methylphenidate 6 years and older. You should know that despite of what the question tells you, the patient develops a tic, your action is to discontinue the medication. Well, Dr. Lopez, what if the patient getting A in school, sleeping well, eating well, because these are all concerns when we give medication. Should I still stop the medication? Yes, you stop the medication. Okay. Then what should I give? Guanfacine or clonidine? Or atomoxetine would be great options. Can be any one of them? Yes. Talked about non-pharmacological management of ADHD, scales for ADHD. So in order to diagnose one with ADHD, it must be a minimum in two different locations. It cannot be my kid has ADHD at home alone. It has to be at home, in school, at home, in the park, two different locations at minimum. You can give the Vanderbilt ADHD scale, diagnostic scales, to the teacher and you, the parent, and you compare both and you bring to the doctor. That one you can download from the internet. However, the corner parents and teacher rating scales is copyrighted. That means you cannot freely download it and use it. So that could be important, right? Could be important in your patient care and could be important as you prepare for the psychiatric nurse practitioner board. Okay, knowing that. We're kind of flying through it because this was a class given yesterday. Just want to remind you a few of the highlights we talked about. Symptoms of stimulant abuse. It doesn't mean that those that express insomnia, tremors, increase of heart rate or blood pressure, palpitation, they do or are abusing of stimulants. However, these are common symptoms that we will find in those who are. Okay. We talked about personalities, right? All these 10 personalities we talked about in detail yesterday. Clusters A, your odd eccentrics. We discussed the difference between paranoid, schizoid, and schizotypal. We also went in detail of the cluster Bs, right? Those are thus far the most complicated and the ones that we are tested the most, especially antisocial, borderline, and narcissistic. And then we finish our personality disorders with the cluster Cs, your anxious and fearful patients. That's your avoidant personality, your dependent personality, and your obsessive compulsive personality disorder, which is very different than OCD. Don't get confused. OCD, the disorder, versus obsessive compulsive personality disorder. That's the personality versus the disorder. Very different. Okay. When we talked about borderline, the first name that should come to mind is Marsha Linehan. Why? Because she created DBT. In fact, she had DBT herself, right? And the goal of DBT is to decrease self-harming behavior, impulsivity, recurrent suicidal behavior. We discussed DC steps, DC, which is an acronym for decrease crisis behaviors. The S is suicidal behaviors. The T for therapy, interfering behaviors. Did you know that the therapist will need therapy after completing a full cycle of DBT treatment? Is very regimented. It's very in line. You must start here, finish here, complete this, do this. Very rigor, right? And you have lots of borderline patients. Everyone will be pulling one side, pulling the other, giving suggestion. So therapy interfering behavior decrease. That is important. Decrease emotion reactivity, decrease passivity, and decrease self-invalidating feelings. What we want to improve is decision making and communication. So use the acronym DC steps can be helpful. And here's your antisocial personality, most likely to be arrested, most likely to steal, most likely disorder to proceed with homicidal behavior. If the question asks about homicidal behavior, you should really be looking at the cluster B, more precisely antisocial personality behavior. Okay? Narcissistic, a sense of entitlement. The company cannot go on if the person's no longer here, right? Basically, they want all the accolades, yet they do not want to put in the work. So, autism, few things to be mindful: lack of social communication and interactions, lack of interactions across multiple settings, i.e., lack of reciprocity and nonverbal communications are the hallmark of autism spectrum disorders. They have problems with developing, maintaining, understanding relationships, stereotypical movements, hand flapping, fixed interests like cars, butterfly, scorpions, snakes, and very regimental on their timeline. If they go to school at 7 o'clock, you better not be late at 7 o'clock, right? If they eat oatmeal for breakfast, that's what they eat for breakfast, nothing else, right? Uh, really, autism is about communication, delay of communications. When someone called their names, they don't respond, and they have this lack of reciprocity. So basically, understanding the broken neuron syndrome is important as well. Risk factors: male, intellectual disability, and family history. We talked about other symptoms that the parents often report. We talked about MCHAT, CARS, ADOS, MRI, and EEG. These are tools to assess um, autism spectrum disorder. We talked about a mild, less severe type of autism, Asperger, right? So when we talked about Asperger, how is it different? There is no significant delay in language, cognitive development, and they also have age-appropriate self-help. So what is different about it is the nonverbal communication, the gestures, the failure to develop peer relationships, right? As you know, autism, they lack the social and emotional reciprocity. So it does Asperger. Okay, so like the lack of imaginary friends. Talked about there is no FDA approved medication for autism, but some of the antipsychotics can be helpful for tantrum aggression, and one to name is risperidone. We did a lots of questions yesterday talking about Reddit, right? Reddit syndrome. We do not treat them, but we refer. If you see a question that is a girl, Reddits are most likely females, and they have a normal growth between 6 and 9 months, just about that time, and they have a delay of coming back or regress of the development that could be Reddit syndrome, especially the acceleration of head growth. The head is growing appropriately and then it stops accelerating, right? Other symptoms that you would see would be loss of purposeful hand movement, stereotypical hand movement, and deceleration of head growth. They can also have seizures um, and the irregular respirations. Okay, so what do? You refer those patients. Okay, what else we talked about? We discussed the 4 disorders that we see often in the test for adolescents. One is being disruptive mood dysregulation disorder, or DMDD. When you hear DMDD, you are to think of an adolescent or child between 6 and 17, meaning like think of it, not that I'm saying it is, think of it as a bipolar little kid. It helps you to get the picture, okay? But they cannot be labeled as bipolar, so be labeled as disruptive mood dysregulation disorder. So they have persistent and long-lasting dysregulation of the mood. Think of them as when they're anger, irritable, they have regular occurrence of intense tantrum. They may need some stronger medication, and most likely they may have a family history of a bipolar disorder. Okay. We talked about mnemonics to memorize. This is what it would look like to you. The second condition is intermittent explosive disorder, better known as IED. Here, they have this lack of impulse control, which is characterized by a sudden explosive unwanted anger. And then they kind of phased out and becomes normal again. The cool thing, well, I wouldn't say it's cool, but one thing to be aware of is that intermittent explosive disorder can also be diagnosed as an adult. So it can be children and adults. Okay. We talked about the symptoms, when and how to diagnose them. We are talking here about the difference between DMDD versus intermittent explosive disorder. Okay. Then we moved on to ODD, which is oppositional defiance disorder. When we say ODD, oppositional defiance disorder, I want you to think of someone that's resistant of rules and regulations, authority. The father figure, the mother figure, the teacher, the principals, they don't care, right? So it's very different than conduct. Is a maybe three steps below from a conduct. But if we don't take care of those children, adolescents, if we don't provide the family with the support they need, they might be at risk to be conduct disorder followed by antisocial disorder. So it's a progress here, right? So the main approach is to provide the therapy for the family. What kind of therapy? Child and parent problem training. So the goal, the number one to do, the important thing is to child and parents problem solving training. Why? To control the mood and aggression. Okay. We do not want them to become or progress to a conduct disorder. That is the ones that are antisocial like patterns, yet they don't have the age. We also talked about how the age in the questions can be a effective tool to discriminate what is and what is not. What is the diagnosis? We talked about strategies to find out what is the answer by looking at the age, right? So personality disorders, they mostly be 18 and over. If they are under, look at conduct disorder, look at ODD, look at ID, look at the other possible options. Okay. So conduct disorder, think of it as a little one who has traits of antisocial personality disorder. So in summary, they don't care about others as long as they get what they want to, that's what they are happy with. More precisely, lack of remorse, more precisely, aggression towards animal or people. That should ring a bell for conduct disorders. Okay. Talked about fragile X, a syndrome that's a genetic condition that causes a range of development problems, including learning disability and cognitive impairment. We talked about major depressive disorder, not to confuse with pseudo dementia or Alzheimer's. We talked about how to differentiate MDD versus adjustment disorder, which is huge, right? We talked about why SSRIs are better to patients who are depressed due to its safety profile against overdose. Okay. We talked about the classes of neurotransmitters that each one of those medications fall into, like SSRIs, lots of serotonin. Hello, Wellbutrin. It lacks serotonin, therefore, usually does not come with sexual side effects. MAOIs, all three of them has dopamine, serotonin, norepinephrine. TCA does not have dopamine, so it comes with serotonin and norepinephrine. We talked about electrical convulsive therapy that can be used for severe psychotic depressed patient that has failed other treatments modalities, or those with schizophrenia that also has failed treatment modality. Those with catatonic can be an option. We talked about treatment resistant, right? And we mentioned head, lungs, heart, and um, adverse effect to anesthesia, meaning that if they have a head tumor or a TBI, or if they have lung problems, or if they have heart problems, or if they are not tolerant to anesthesia, those would be contraindication to ECT. We also said the number one symptoms that we see after ECT is a short-term memory is being effective. Like, I don't remember what I had for breakfast this morning. Long-term memory should not be effective, and even short-term memory should regain its normalcy after 48 hours or so. But think about it, they'll be under anesthesia. So if you cannot tolerate anesthesia, then it would not be a good process for this person, right? A good procedure. We did lots and lots of questions, okay? We talked about risk factors for suicidality and how to distinguish when we have A, B, C, and D suicidal patients, and how to find out which one has the highest risk. We talked about bipolar disorder. What's the difference between bipolar 1, 2, and cyclothymic? And what kind of medications do we should use? Here is another component. People get caught up on this all the time. So we said, get a piece of paper, write it down DNS, put in a major depressive disorder, put in a Tourette, put in a ADHD. On the same piece of paper, now we're going to get another bucket, which is called GGGNS, glutamate and GABA plus DNS. And that you will put bipolar disorder. So it's the lack of GABA plus a lots of glutamate plus an imbalance between dopamine, serotonin, and norepinephrine. That is the neurotransmitters involved in bipolar disorder. Cyclothymic is the one that does not meet the criteria for bipolar 1, 2, and major depressive disorder. So therefore, it falls in this place where we call them cyclothymic. Gold standard when we're dealing with bipolar disorder is lithium. Why? It is neuroprotective, right? It helps those with schizophrenia as well, right? Because it's neuroprotective. Bipolar 1 versus bipolar 2. Thyroid functions. You need to know. We discussed how the purple book is not correct on the thyroid value. The right value is 0.525, not 0.5 to 10. Okay. We discussed when the TSH, right, is low, then we're likely to be looking at hyperthyroidism, given if the T334 is high, TSH is low, T334 is high. That is possible hyperthyroidism. Now, when the TST is high, T334 is low. Now we're looking at hypothyroidism. You should know this in detail. We went over, did questions, and yet some people still got it incorrect. So we went over again and again until all 40 students in our class really understood the concept here. What hypo and hyperthyroidism looks like, right? Very important to know. Went over liver functions. ALT, ALT. If you look at the letters, is before the L is before the S there in the middle. So I always memorize ALT 5 to 35. I add 5, so I have 5 to 40. Find a way that it's easy for you to memorize. Even if it only makes sense to you, it's okay, right? We talked about alcohol use disorders, what kind of labs we should be looking at. Uh, Glutamyl transferase, mean corpus callosum, corpus callosum volume, and others that we should be looking at is a PTT, uric acid. We would see a total cholesterol and triglycerides increase as well. Conversion disorder, think of it versus adjustment disorder. Think of it conversion disorder. It was a crisis first of some kind, followed by the symptoms. What kind of symptoms? Neurological symptoms. What are they? Mutism, blindness, can't walk, right? So, for example, my mother died. Few weeks later, I can't see. I'm blind. My mother died. Can't walk. My mother died. I can't urinate. Something along those lines, right? When we look at a adjustment disorder, it would be a crisis. Now I'm depressed. A crisis. Now I'm anxious. A crisis. Now conduct disorder of some kind. Okay. So you kind of have to understand the difference between conversion, somatic, malingering, um, adjustment disorder, major depressive disorder. All these can be very close. So you have to look what is the cue in a question for you to get this question correct, so you can get the right diagnosis. We talked about in detail PTSD versus acute stress disorder. Remember, if you only look at the time frame, you may be fooled by this question. So if someone has bipolar disorder in a depressive phase, you would not diagnose with them with major depressive disorder. You'd say bipolar disorder currently in a depressive phase, right? So PTSD and acute stress disorder is the same thing. If one has a PTSD diagnosis, they cannot be acute stress disorder. So PTSD has been diagnosed doing well or not doing so fine. Then you had the incident that triggered the PTSD. So now the diagnosis PTSD, not acute stress disorder. Right from the gig, if it's more than 30 days, PTSD. If it's less than 30 days, acute stress disorder. Okay. And they can be very, very confusing. So I highly, highly recommend that you do our question banks and get these types of questions. The more you do, the more clear it becomes. Okay. Prazosin, right, for nightmare, but it is a antihypertensive medication. So be careful with the amount of those medications that you prescribe. Talked about EMDR. I mentioned that it's very, very important that you know EMDR, the phases of it, because questions could give you the phase and ask you to identify which phase it is. So it's right here. If you don't have it, take a picture on this PDF right here, the phases of it. Let me see. Okay, it's kind of too big for you to take a picture, but you should know in detail which phase it is referring to. Okay. So, for example, desensitizations, desensitizing phase or desensitization, using eye movement to process distracting memories, following the therapist's fingers on the movement back and forth while recalling the car accident, for example, would be a one. And then the question asks, which phase is that in? Or installation phase is strengthening positive beliefs about the traumatic event. For example, replace I'm not safe beliefs with I am safe now. the body scan, releasing any lingering physical tension or discomfort associated with the memories. Okay, very important. So make sure you get a hold of your PDFs and really talking to yourself what each one of those phases, what's happening in there. Okay, you only have to do this for a few weeks, and then you will achieve your board certification. So I really, really warn you to study hard, study intensively, enjoy the journey that you are currently in, so that you can have your absolutely best life in just few weeks. Okay. We talked about obsessive compulsive disorder, risk factors like first relative, understanding pandas, right? Very, very high yield. Talked about which medications to prescribe, tics, and movement disorders. We talked about how OCD sometimes can have tics. And because you hear tics, you go straight to Tourette's. It's incorrect. You have to fully understand OCD, and you have to fully understand movement disorders. When it comes to Tourette's, you need 2 motor symptoms and 1 vocal for over 1 year. What if you only have movement? Then it's a movement disorder. What if you only have a vocal? Then it's a vocal tic, right? So, and if it's a mixture, then you need to find out which one it is, which one falls into. Okay. Remember, ADHD develops a tic, stop the medication. And we did lots of questions. Talked about schizophrenia, high yield, probably about 5 to 10 questions you'll get alone on schizophrenia. If you put someone in a MRI, you would see enlarged ventricles. If you look at the neurotransmitter, again, get your white piece of a paper, only put in the neurotransmitters there, understand that there is an excess of dopamine, excess of glutamate, little to no GABA, little to no serotonin. Okay? Understand that mostly it's pretty rigid here that males 18 to 25, females you add 5 more, 10 more, so 25 to 35. Knowing that why is it important age? Because if it's a first breakthrough, someone comes to ED with the first breakthrough reported of schizophrenia at the age of 45, male, you know this is unlikely to be truth. It's probably related to drug or something else. Okay? Where does schizophrenia come from, right? How does it happen? Well, we theorize that is a inadequate synapse formation, excessive pruning of the synapse, exitosis, death of the neuron, and an insult to the intrauterine insults, right? Which could be lack of oxygen, prenatal exposure to toxins, maternal malnutrition, and so on. We went on to talk about the positive symptoms, the mesolimbic pathway. Negative symptom is not the lack of serotonin, but the lack or decrease of dopamine, where mesocortical pathway, right? Talked about mnemonics, symptoms of it, pharmacological management, the Zell's drugs, right? Ziperidone, aripiprazole, Latuda, the skinny drugs, those who would least like to cause weight gain, least likely to cause sedation, Abilify. Okay, we talked about ACT, right? Effective treatment for what? To keep patients out of the hospital. How does it happen? It's a 24 hours treatment basis for the patients. Why? We want to keep them moving, living their best life with the condition that they have. It could be bipolar, it could be schizophrenia, or other conditions, right? The important thing is keeping them out of the hospital, in the community, doing the best they can with the resources and support that they have. Okay. So it's a lot. We covered about 4 hours here yesterday, right? And but the good thing is you have your PDF and it's available to you at your fingertips. There is absolutely nothing that we covered yesterday that should be surprise to you. So we went over module 1, 2, and 3. Next week we'll go over module 4. Every Friday we're meeting live. Every single day, you have the entire course at your fingertips. You don't even need to wait for the live content. You come to the live content ready to teach. It's more of a review. It's more like, yep, I got it. Yep, I got it. Yes, I got it. Feeling good, doing well, right? This is the most important test of your life. You should take this very, very seriously. Take it very hard. Christmas right around the corner. Make that be your Christmas present. Okay. Leave no stone unturned. As you walk in the test center, I want you to feel unstoppable. I want you to feel that you deserve the place on the table, right? You're primed for success. This is your year, right? This is your year. That's what you worked for so hard your entire life, and you are very, very close. Okay. That being said, uh, today it concludes today's event. I'll give you a few minutes to ask any questions that you may have. But if you are interested in our course, go to www.mpexamcoach.com. Next Friday, we'll meet every Friday for live. But again, the entire course is available to you at your fingertips. It's pre-recorded. You can catch up, or you can just attend the live courses as you wish. Okay. Any questions? Okay, I'll stop recording here. And then if you guys have any questions or concern, please let me know. I'll stay on the side here to help you.